Well, good day, everyone, and thank you all for joining us today. And we are encouraged by the overwhelming response to this town hall. Over 750 people registered to attend, clearly an indication of the continued thirst for knowledge by our EMS providers. We want to start by saying that we recognize and respect that the decision regarding this or any other vaccination is a deeply personal decision, and each person will make the decision that they feel is in their best interests. The goal of this town hall is to answer some of the most common questions regarding the COVID-19 vaccine so that you'll have all the information that you could possibly have in order to make that informed decision. We'd like to thank our partners in this event, the National Association of Emergency Medical Technicians, the National Association of EMS Physicians, and the National Association of State EMS Officials. This webinar is being recorded to be a continual resource for those who are unable to attend live. After the webinar, it will be provided to the sponsors so that they can post on their various platforms. Due to the large audience, all attendees will be muted for the duration of the town hall. Because we want to be responsive to you all, many registrants sent in questions in advance, and we have queued them for discussion today. However, during the webinar, in the event that we don't cover all the questions that you have, you may add questions in the queue through the Q&A function in the bottom of the menu bar. So you can see it here. You may have to hover your pointer over the webinar screen in order to reveal that Q&A function. Clicking on it will reveal a dialog box that you can use to text in any questions that you may have, so that as we have time at the end of the webinar, we'll be able to answer those questions for you. We want to introduce our panel today. We are deeply honored to have 4 of the most outstanding EMS medical directors. Each one of these gentlemen, these distinguished physicians, have unique and keen insight into the COVID vaccine. Here they are sort of in order. Dr. Ken Shepke is the EMS Medical Director for the state of Florida. He's also the Medical Director for Palm Beach County Fire Rescue. Dr. Shepke has taken the lead in doing a lot of education regarding the vaccine and its scientific base and efficacy. Dr. John Kramer is the Director of the Office of the National Highway Traffic and Safety Administration's EMS office and has been the team lead for the HHS Healthcare Resiliency Working Group EMS pre-hospital team. Dr. Kramer and his team have been hosting numerous conference calls, listening sessions, and really been an advocate for EMS throughout the duration of the pandemic, certainly at the federal level. Dr. Veer Vithalani is our medical director here at MedStar. He is the Assistant Medical Director and in the Office of the Medical Director for the Metropolitan Area EMS Authority and the Chief Medical Officer for MedStar. He has been a phenomenal resource for our community, presenting at city council meetings, several media events, and also has been hosting an online forum for our personnel, answering questions that they have as we, again, provide information to our field staff and our entire team on the coronavirus vaccine. Dr. Doug Kupis is the EMS Medical Director for Geisinger EMS. He also is the Medical Director for their Mobile Integrated Healthcare Program. He is an NAMSP board member and on the NASEMSO Medical Directors Council. We are also thrilled to announce today that Dr. Kupis has been named as NEMT's new medical director. So we're going to add that title under his picture there. We know that Dr. Kupis will do a phenomenal job being an invaluable clinical leader for NAEMT. He also joins Dr. Jeff Jarvis, who has been named as NAEMT's Associate Medical Director. So congratulations, Dr. Kupis and Dr. Jarvis. Okay, let's dive right in. So the first question that we hear most often, not only from the EMS community, but also from the general public, and we're going to ask Dr. Shepke to answer this question because he's done a lot of research into it. How does the vaccine actually work, and how was it that it was developed so quickly?
Ready to go the moment they proved it worked. Number 2, when you do a study, especially on a vaccine study, you give half your population the vaccine, give the other half a placebo, and then you have to wait for those people to go about their daily lives, and you need your study population to get infected, develop a certain number of infections. And then you kind of look at it and say, all right, of the people that got infected, how many had the vaccine and how many got placebo? And that you can see the difference. Say, all right, well, the placebo got a lot of infections and the vaccine not so many. Well, when you do something like Zika or Ebola, there aren't that many infections that develop over time. So it takes a long time for your study population to get infected. But when you have a worldwide pandemic where hundreds of thousands of people are becoming infected every single day, your study population gets infected very quickly. So you're able to reach that statistical mark that you need to reach to decide whether the vaccine is effective really, really quickly. So it's really simply three things. Matter of science, it's really fast now. The fact that the pandemic infects your study population really quickly, and the fact that we mass produced the vaccine at the same time, even before we knew the vaccine worked, so it was ready to go once they proved it worked. That's basically how they did it so quickly, and it works brilliantly. It's quite effective at the tune of 95% effective at blocking symptomatic infection.
You know, Ken, one of the things that I think may be helpful, and you pointed it out very nicely, you know, earlier, you know, it would take decades to develop vaccines. And the long part of that was actually to develop the vaccine. And then before it could be marketed, you know, it had to go through all the studies. Well, we compressed the forward end of that. So, you know, it took 60 days as opposed to decades to get the vaccine. We didn't compromise on the clinical studies then to look at the effectiveness and the potential downsides of the vaccine.
That's absolutely correct, and that's a great point.
Okay, let's move to our next question. And again, these were all sent in advance. Are there differences in the rates of vaccine acceptance among EMS providers, nurses, and physicians? And if you think there is, why?
And this is Doug. I'll take a little bit of a stab at that. First of all, we were talking a little bit before we got on this, and you know, it's difficult to say what the exact rates of acceptance among different providers is, because that does seem to vary, whether you're talking to nurses, physicians, EMS providers. It also seems to vary across parts of the country. The thing that I have observed that I think is more true is that no matter what the rate of acceptance was before the vaccines became available, when we saw some rates that were published from surveys that were, you know, maybe 55% of EMS providers in some systems said they would accept getting the vaccines. What I have observed is that since the vaccines have become available and offered, a lot more of the science and good information has become available through lots of different venues to people, and a lot less of the myths are circulating. And so immediately people started to get good information and those rates went up. So your system may vary. I know that locally we had an informal poll and the physicians almost universally said they would get it. And there was some reluctance among nurses. But after a couple sessions similar to what we're doing today, the nurses got on board very quickly also. And I think the same is for, you know, EMS providers or any other group. Information is causing people to want to get this. They're realizing it's safe and effective.
Anybody want to add anything? All right, let's move to the next question. By the way, just so everybody knows, we have about 19 questions, so we've saved room to add a couple at the end, and we'll do that. So here's a question. If the survival rate is so high, why is there such a push for the vaccine?
I can take a stab at that if you want. And that's a great point. First of all, I've heard this thing compared to the flu many times, and it's nothing like the flu. There's a much higher rate of both death, hospitalization, and long-term disability from this, even among young people. So right now you are faced with a choice, because this pandemic, just look into the crystal ball a little bit, the pandemic is not going away until we have somewhere between 70 and 85% of our population have immunity to this virus. So you have a choice. You can get vaccinated, and you have a good scientifically produced vaccine that's not even a virus, it's just messenger RNA, or you can wait and you can get infected and get antibodies that way. Even young people are developing what we call long hauler syndrome. I have several in my own fire agency, fire paramedics, who they're still out of work months and months later, even though we're young, healthy, have zero risk factors. So you can do the Russian roulette way, I like to say, and let the infection get you, or you prevent the side effects or have that gamble and take the vaccine and deal with a very well-known side effect profile for the vaccine. Not to mention that if you wait for herd immunity to develop, we're going to lose many more hundreds of thousands of the elderly at-risk population and other folks who are younger but have comorbidities. So we really want to rapidly get to this herd immunity and vaccinate the folks that are certainly high at risk, but even the young folks, prevent the transmission. And keep in mind one more thing. The virus has the ability to evolve over time. The longer you let this virus stay out there, the more likely it will be that the virus will evolve to avoid all these wonderful therapies that we're making, the antibody therapies and this vaccine itself. Hasn't happened yet, but the longer we wait, the more likely that will happen.
Ken, I would add the other important part about this is when we're talking to healthcare providers that are on the front lines, and especially EMS, playing that Russian roulette also takes you out of service for a period of time from your agency. And when agencies get multiple people that are infected, that really diminishes their ability to care for the public, not only for the surge that we're seeing from COVID care and transports, but also the surge that or the other baseline emergencies that occur in your community. So, to be frontline providers, being out for any time and having a number of people out is a real issue.
Just to expound on something you both sort of mentioned, I think it's important to, when you talk on an individual level, that this is what people worry about, but from a population level, right? When you look at the world's population, everyone who has not been infected so far is susceptible to this virus. And so even if it is as low as 1%, that's a huge amount of people that we just don't have the resources to care for at any one given time. And with the way exponential spread works, like a lot of us are experiencing right now, every day that goes by, you get more and more and more people per day getting infected. It's not a linear curve. The more people that are infected, the more people that it continues to pass on to. And so we really do need to look at this as a pandemic. It is a worldwide phenomenon. It's not just one city, one state, or one country. And so we need to keep that in mind when we make these decisions. It's not just about you, it's about the whole world.
Yeah, that was the point I was going to make too, Val. That's very good. I mean, it's candidly, the likelihood of you getting infected with this is greater than the likelihood of getting infected, for example, with seasonal influenza. It's folks have sort of akin to measles, which many of the folks that are listening to this webinar never had to worry about.
All right, let's move on to the next question so we can save some time. People who've had the COVID-19 are told to wait 90 days to get the vaccine. Why is that?
Oh, that's a pretty simple answer. It has to do with we know that natural infection can protect you for at least 90 days. So when vaccine supply is short, we want to give it to those that are at highest risk. And if you're at low risk because you've already had this and survived it, we know you're protected for 90 days. That's basically why it's a supply.
Yeah, I mean, there's nothing wrong with it that we know of, getting it within that 90-day period. It's just there is evidence that you do have some of that natural immunity, and we can use the vaccine to vaccinate some folks who may not be in the same situation. But if you're offered the vaccine, you've had COVID, and there's enough vaccine supply, there's nothing wrong with getting it within that 90-day time frame.
But let me just say one more thing on the protection level. The vaccine gives you a protection level of antibodies that are far, far higher than natural infection. And that's a really important point. And that's why we're seeing people get reinfected over and over with COVID-19. It's pretty weak protection you get. The vaccine, when they compare it to folks who had survived COVID, it was so way higher than it was from natural infection. The protection you get from the vaccine is much better.
I think one of the other things to keep in mind too is that, at least based on the studies that we have so far, the vaccine will prevent you from getting serious COVID, i.e. ICU level disability or level requirements care, and potentially some of the long-term effects. It will not 100% prevent you from contracting a COVID infection.
Okay. Next question, what kind of side effects, and will you get them for both doses?
I can take that. So, I think adverse effects in both the studies for both Pfizer and Moderna were sort of broken out. They call them local reactions and systemic effects. So the local reactions are things that you would expect anytime someone stabs you in the arm. So, pain, a little redness, some swelling. They are a little more pronounced in this population or these vaccines. And a lot of people are comparing them to a previous vaccine that they've had. And there is a good chunk of people that get pain, redness, swelling, but only a subset of those actually are something that's concerning or lasting more than a couple days. And then from the systemic effects, they're generally what you would feel when you get any sort of vaccine, such as the flu vaccine, or if you have a mild viral illness, so things like fatigue, some myalgia. Both studies have shown that the second dose seems to be a little more pronounced side effect-wise than the first. But generally speaking, not only from what people have elaborated in the study, but for a number of us who have both gotten the vaccine and have talked to a lot of our colleagues, in general, it is much better than getting infected with COVID. It is, on the whole, definitely worth it comparatively. And the one thing that keeps coming up a lot, especially that wasn't seen in the studies but popped up pretty quickly afterwards, was a question about anaphylaxis or severe allergic reaction. And in a beautifully timed fashion, the CDC put out some interim data yesterday on anaphylaxis, specifically from the Pfizer vaccine. So they said, this is the data as of the 23rd of December, there was 1.89 million doses of Pfizer vaccine administered. 4,000 or 0.2% had any adverse reaction. There were 21 cases that were deemed to be true anaphylaxis. So 21, that's 11 per million doses that are given. It's an extremely small number. A majority of those, 17 of them, had a history of anaphylaxis to something. So they already had a ramped up immune system. And then 20 all went home after getting some epinephrine in an emergency department. So no one was admitted to the hospital. There were no deaths associated with it. And so on the whole, this is significant. And when you're talking about such a rare event, it's almost impossible to say that it was from the vaccine, as opposed to anything leading up to giving you the vaccine, whether it was the needle or the syringe or the gloves or anything else. And so I think on the whole, it's pretty safe and yeah.
Yeah, the other thing to remember with the side effects is the fact that you're experiencing side effects reflects the fact that your immune system is responding to the vaccine. You're not getting the virus, you're not getting the disease. Your immune system is starting to create the immune response that you're hoping from the vaccine.
And I think it's important also, a lot of people really focused in even on those mild effects of, you might have a day of muscle aches or a mild fever. That is still a small number of people that get the vaccine that get that, or a small percentage. I think it's important to not focus on that and keep that in mind, that it is not like everybody gets even those minor symptoms. I would encourage everybody to consider, if you get the vaccine, to go get the app that the CDC has that actually sends you a little reminder once a week and asks you about symptoms and side effects, because I think the more data that we can help them collect, the better off we are. And it's a relatively simple thing to do. You get a little ping and it just has a checklist of which side effects you may or may not have had.
So real quickly, because I know a lot of us are screening for COVID-like symptoms, and the vaccine, pretty much any vaccine gives you these immune system being turned on side effects. But there's a difference between, some of the difference between COVID and vaccine side effects, things that vaccine does not give you. It will not give you a cough. It will not give you a sore throat. You will not get short of breath. You will not have altered taste of smell or no altered taste or smell. And that's some of the things that you can use to differentiate between true COVID and post-vaccination symptoms.
Excellent, excellent. Okay, let's move on to the next question. Will this be a less effective strategy in fighting COVID-19 if only 50% of the population gets vaccinated?
Yes.
For those of you that can't see their screen, they're all nodding.
I think it's important. It's sort of funny. There's going through this pandemic, there's a lot of people that have been suggesting herd immunity as a strategy, right? And now they've been suggesting it through infection, which I think all of us on the panel would agree is a very bad idea because it leads to millions of deaths and a lot of unsafe practices. But there is a really easy way to reach herd immunity, and that's to get as many people as possible vaccinated with the safe and effective vaccines that we have. And I think that's just the reality of it, is that there's always going to be some people that cannot get vaccinated. It's the concept of the herd immunity, is that if a majority of us have it, then the likelihood that any of us get it to then pass it on to someone who's not infected is exceedingly low. And to be fair, this is how we've eradicated a number of diseases in the world. You know, I never had to worry about mumps or polio or all these other things. And that's because we've had vaccines for years. And I think this is just another one now in our armamentarium of trying to get rid of this. But I don't see this pandemic really going away in any other way.
Along that point, you've all heard about the new strains that are coming out of the United Kingdom and elsewhere that are more transmissible. The rate of transmission, there's a mathematical formula used based on the rate of transmission to kind of figure out or project, make an educated guess on what percentage of population needs to be immune to stop the spread. The more efficient the virus is at infecting humans, the higher the percentage of people in the country need to have immunity before we can make this thing stop. So another reason we're basically trying to speed ahead of evolution of this virus. So the faster we can knock this thing down, the better for all.
Okay, excellent. Thank you, gentlemen. Let's move on to the next question. This is one for doing on-site vaccines. If we offer them on-site, is there a time that the associate needs to be monitored after the vaccine, and can that be in their work area?
Yeah, I don't mind taking, if you guys don't mind. So yes, for both the Moderna and the Pfizer, there's a 15 minutes monitoring for both of them. However, if you have a history of allergic reactions, the CDC recommends at least 30 minutes of monitoring. So that's basically what we do in practice. And I would suggest, in addition to monitoring, that you have something there that can deal with an anaphylactic reaction. Like Veer said, it's relatively rare, maybe on the order of 1 out of 100,000. But you should have either an EpiPen or epinephrine with paramedics or something of that nature in your environment in case you get one of those rare reactions.
And I would suggest not just having the epinephrine or that sort of thing, but you also have to have people that are comfortable with treating allergic reactions, because we are using lots of vaccinators, and some of them have varying degrees of experience in treating a severe allergic reaction. Your vaccine site should have somebody that has that experience. The other thing about this wait period is I think it creates a little bit of a nuance for the drive-through vaccine centers. And, places are still doing drive-through, and I think it's a great way to do it when we get to mass volumes of vaccine to the general public. It'll be particularly interesting way to do it, but you have to have some way of having these folks go into a separate lot and wait for 15 minutes, because the last thing you want to do is have somebody, lightheaded and hypotensive driving out of your lot 2 minutes after your vaccine.
Yeah, and just to add back to that report that the CDC put out, the median time to symptom onset was 13 minutes. So it's actually 15 minutes totally makes sense. And given the fact that the majority of those patients had a history of anaphylaxis, they would have been waiting for 30 minutes anyways. So I think the recommendations are solid.
Excellent. Thank you. Let's move on to the next question. Are there differing strains of the virus that the vaccine may or may not be able to provide protection from?
So, I think right now, best we can tell, the two big strains that we've been talking about are the UK strain, which is more infectious, but maybe doesn't portend any more severe mortality or sort of outcome. And the second one is the South Africa strain that's recently sort of come out, which I think we're still trying to get grips on. I believe Pfizer and Moderna both have stated but not published that they have found their vaccine to be effective against the UK strain, at least. I think the important thing to understand is that the antibodies are produced to the entire spike protein, and the mutations that we're seeing, and the reason there's concern over the mutations, is that the mutations are occurring on the spike protein. So the question is, at some point, will that mutation be so much that the antibodies won't affect it? I think there's some benefit or some way to minimize that concern is if the spike protein changes so much that the antibodies can't react to it, then it probably also can't latch into our ACE receptors, which is where it's binding as well. But like Dr. Shepke said, it's only a matter of time before these things continue to evolve. And we need to minimize the spread as much as possible in order to prevent something like that from happening. And there was a question I saw that popped up about whether these strains they're being tested for or not. And I think the important thing to understand is when you test for COVID, you're testing for the RNA, right? So it's a PCR and it's looking at the sort of middle of the COVID virus. But it's only when you sequence the genome of each individual infection that you're starting to see the changes in the gene of the spike protein. And in reality, only some countries are doing a great job of gene sequencing. And even within the US, only some states and locations are doing pretty consistent gene sequencing. And so I think that also, I think a lot of these variants have probably been around for longer than we realize. And the states that are doing the gene sequencing are starting to pick them up a little faster than some of the others.
Okay. Now we get into the nitty gritty now, right? So once vaccinated, can we relax a little bit? Do we still need to be doing all the PPE and decontaminating stuff?
Absolutely, at least for a period of time. I think, there are a couple of things we don't know about this well at this point. We don't know, once you're vaccinated, you've got some protection, but we don't know if you can still pick up that virus and carry at least enough of it to transmit it to somebody else. I think that the other issue is that as we're getting to the point when before we have a vast majority of the population vaccinated and herd immunity, it's going to be very important to continue to use those precautions and not just throw caution to the wind. Don't forget that some, these are 95% effective. That means that they do a great job of reducing your risk, but it's not 100%. So by using proper PPE, you have a much better chance of turning that 95% into 100% protection for you.
Yeah, and I think the other thing, especially when we talk about a lot of the measures that are in place now, they're population measures because it's not just about the incidence of the disease, right? How many new infections we have. It's about the prevalence, how much disease is out there. And so I think the vaccine distribution is great and it's going to help us decrease the incidence, the number of new people getting infected. But until we can get the prevalence down in our communities, we really can't let up on mitigation measures. And so once we're at a low enough prevalence where not only is it not really out there, but everyone who could potentially get infected is now vaccinated, that's where I think we can start scaling back. The reason we, in our agency, we wear half mask elastomeric respirators on every call. That's because the prevalence is so high that even if someone's not complaining of COVID symptoms, they could be infected and infectious. But once we get things way down where that's not the case anymore, then I think that's the time to relax. But I honestly think that we are months away from that. And if what I've been hearing from a number of people, they say, well, I'll get the vaccine, I'll just get it a year from now. And if you want 2021 to be exactly like 2020, then that is a great mentality to have. But the faster we can all get vaccinated, the faster we can all eliminate this, the quicker we'll be able to let go of some of these measures.
Yeah,
Matt, I would, sorry.
Go ahead.
I would specifically speak to the first part of this question that's on the screen right now too, related to decontaminating. So, should you keep wearing PPE is one question, but I think most would feel that, common sense would say we need to have that high level decontamination of the vehicles and equipment through this pandemic, because your entire team might be vaccinated, but the back of the ambulance isn't meant to protect just you. You have to protect every patient that you put in that's not vaccinated too. So that decontamination is going to continue for months, just like the PPE will.
That goes to Veer's comment about the prevalence in the community. And we have to continue to remember that the vaccine does not prevent you from potentially being infected or infectious. It prevents severe disease from developing.
Or symptomatic disease, right? And to be fair, I am hoping and I am very optimistic that it does, but we don't know yet, right? The data isn't published yet, but there's if you got super nerdy like most of us and looked way in the depths of the FDA briefing on Moderna, they actually published some really early data. But again, we don't have the pre-second dose PCR test data yet, for example. But I'm optimistic.
As usual, Veer's beat me to it. That's kind of that was what I was going to bring up, is that we still have a lot of data coming in. We don't know for sure whether you can have asymptomatic spread, even though obviously this thing will keep you from getting symptoms yourself. But there is some data, at least in animal models, that it does prevent even asymptomatic spread. So I'm hopeful that we'll find the same thing in humans. But we just don't have the answer yet today. But those studies are going to be done, and we will get that data at some point.
All right, thank you guys. Let's move on to the next question. Is it still unsafe to hang out with someone who's already has been vaccinated or has been infected?
Boy, wouldn't it be great if we had the answer to that? Yeah.
We'll start a trial.
I'm sure some of you have seen the news about vaccinated healthcare workers being invited to the Super Bowl. And if it could be one big maskless Super Bowl, wouldn't it be fantastic? But I don't think we're there yet. Much to the same answer that we just gave on the last one. Until we know that you're not infectious, you may not be symptomatically infected, but until we know you're not infectious, the truth is still there. And in reality, like a lot of the answers for the vaccine, we should treat vaccinated people the same way we do people who previously had infectious or who previously have been infected. You still got to follow the rules. We still don't know enough. We'll get there, but we don't know yet.
Okay. I saw something about Bell's palsy. What's the deal in this whole Bell's palsy and the vaccine thing?
Dr. Kupis, you're muted if you're...
I have to say that first I learned something when you put this slide in, because I did not realize that Sylvester Stallone has had lifelong Bell's palsy, and his is not from an infection. So we don't want to give anybody a false impression that this came from either an infection or a vaccination. It was from a birth injury to his facial nerve. But these kinds of things are raised related, neurologic issues are raised related to vaccinations. What we know from the initial Pfizer data in the first 44,000 patients and the Moderna data is that there were a few cases of Bell's palsy, but guess what? There were also a few and similar number of patients of Bell's palsy in the patients who did not get the vaccination and got placebo. So, our society has, when you take hundreds of thousands and now millions of people and give them a treatment, some of them are going to get Bell's palsy no matter what happened over the next months or years. And what we know from the study is that the rate of Bell's palsy was essentially the same as the rate of Bell's palsy in the study participants who got placebo and did not get any vaccine.
Okay. Thank you, sir. Can the vaccine compromise respiratory or cardiac symptoms in an otherwise healthy individual, and are those effects long-term?
Well, we know the disease certainly can, but we have not seen that from the vaccine. And that's one of the reasons why I personally feel the vaccine is the safer route to getting my personal immunity. You'll have to make your decisions for yourselves. But when I mentioned before about the long haulers, one of the issues with those is we see there may be permanent or at least semi-permanent, well, just to see how long they stay sick for, damage to the lungs or cardiovascular system, even in young, healthy individuals with no risk factors. Once again, we've got several in my own system. So we know COVID, there's been a lot pointed out in the news media about the deaths. There's been much, much less about the long-term disability that this disease can cause, even in young, healthy people, and specifically the respiratory and cardiac systems that are affected. In fact, you may have seen in the news, we had a University of Florida basketball player that went into cardiac arrest. And that we don't know for sure. I'm certainly not violating HIPAA because I'm not giving you his name or anything that was else that was in the news. But we know that this can affect your heart in the long term on some of those folks. And we still don't know for sure when we should athletes to go back to being athletic after they've had COVID because of these concerns. So it's definitely an issue with this particular virus that some people, it is the minority of the people, but some people get these really bad long-term effects and disability from this. That we are not seeing from the vaccine.
Next question. Can you still spread COVID-19 if you have been vaccinated?
Yeah, so we sort of covered that. And while I suspect the answer will probably turn out to be very unlikely, just because of the way it works and the way how robust the immune response gets, until we really have that answer, we have to be cautious, like all my colleagues have been saying, about allowing this pandemic to continue to spread for multiple reasons. So I think it's safer to assume that that's still a possibility until we have the data to prove that that's not a possibility, because right now that's one of the unknowns.
Okay. Causing infertility. I know, Dr. Vithalani, you talked a lot about this with some of our internal folks on a chat we had. What's the scoop here?
Yeah, so I first saw this right after the Pfizer data came out. There was a internet misinformation meme put out that basically said that the vaccine is going to cause antibodies to placental proteins alongside antibodies to the SARS-CoV-2 spike protein. Therefore, it's going to lead to infertility. And I think there's a few both theoretical and actual problems with that belief. One, as Dr. Shepke explained at the very beginning, all the vaccine does, all the mRNA vaccine does, is it makes some of your cells exhibit spike protein. So it doesn't give you real infection, but the spike protein is the same. And your body develops antibodies to the spike protein, whether you are really infected or whether you've been vaccinated. It's pretty much the same antibody. If this belief of infertility were true, then all the young women who had been infected and gotten recovered would have therefore developed antibodies to their potential placental protein. And we would have already seen, now almost a year into this pandemic, a rise in the amount of first trimester spontaneous miscarriages or infertility, and none of that is true. And so I think just purely on a realistic level, I think we can put this aside. But the other thing is the placenta is not held together by a single protein that can be destroyed, even if there were autoantibodies created to this. The spike protein is significantly shorter than the actual placental proteins that are in question. And there are a number of them, not just one. And so there are some good articles out there written by actual scientists with actual information about how this myth is not the case. I have seen it evolve, much like the virus, into, well, there's 2 years, or you shouldn't have unprotected intercourse, or if you're pregnant or not pregnant, that you shouldn't get it. I don't think there's any scientific merit to these concerns. Again, everyone makes their own decision about this. I have 2 family members who were pregnant or recently pregnant, both got vaccinated, and believe in the science behind this.
Okay, any other comments to that? Excellent. Moving on to the next one. How long after you get the first and second vaccines does it take to become effective?
Matt, this is Doug. I'll take this, but I think that the chart on the next slide will be helpful in describing this. So this is the chart that shows from the Pfizer vaccine study the cumulative incidence of getting COVID-19 after getting vaccinated. And you can see that for the first almost 14 days after the vaccination, people are at pretty much the same risk of getting COVID as they were prior to vaccination, which is why we see some people after vaccination develop COVID. It's not protecting you at that point. But then at around 14 days, you start to see the curve separate. And I know there are people that have looked at their antibodies. It is not recommended. Some people have asked, well, should I be getting some antibody testing just to see when I've started to develop the antibodies? It's not recommended that people get antibody testing, but that is being done scientifically to follow these reactions. So certainly in the first couple of weeks, and probably not until you get your second vaccine and you're a few weeks past that, are you really going to be sure that you're getting that benefit. And again, remember, it's 95% effective, not 100%. So we can't say anybody's surely getting the benefit, but the vast majority do.
I love this graph so much. I was joking with the other panelists. I'm going to blow it up and frame it on my wall. There's a great comic that says, make a graph in science that doesn't even need to be explained. It just shows, well, this is the people who got vaccinated. And I think it's important to remember here, as you notice in the first sort of 7 to 10 days, that graph lines up exactly. But those individuals could just as easily and probably were infected immediately prior to receiving their vaccine, like Dr. Cooper mentioned. And I think that's important there. You'll hear these numbers of 95 and 50% after your first dose and whatnot. I think it's important to note that when you build a study, you have to set cutoffs. And so in the Pfizer data, it's 7 days post-second vaccination. And in the Moderna study, it's 14 days post-second vaccination. But that's just the time period in which they cut off their data to say, okay, now they should be in reality. But that's why I love a graph like this, is because it shows in reality, it's probably a little earlier than that. And so I think there's some protection from that first vaccine, but the second one still really drives it home.
That's what I was going to point out. That even though it looks like the vaccine's really protective after, say, 13, 14, after shot number one, keep in mind that we know that human immunity to coronaviruses wanes normally. It gets weaker over time normally. So this is not a graph that says don't bother about getting the second shot, because when you look at the immune response, that second shot's really what gives you that nice boost in the immune system that we think will be very highly protective.
And from a purely scientific standpoint, there have been people that have suggested, well, maybe you could just skimp and get away with one and vaccinate twice as many people. The problem is, when the study has been done the way it's been done with a second dose, these results are only results we can predict if somebody does that. If somebody changes their approach, then we have no idea what future or long-term immunity is going to be.
All right, any other comments? Awesome. Winding down here, so we're going to have some time for some online questions. How long does the vaccine last? Is this going to be like a every 3-month thing that we have to get boosters?
So, the actual papers themselves, it was kind of nice. The FDA set the requirements for the papers, right? So they said, hey, you have to give us 2 months minimum of follow-on data. And I think for Pfizer, they actually had, I think it was 14 weeks worth of data sort of afterwards for a chunk of their patients. And the reality of it is, like a lot of things, we don't know yet, because the first people that were vaccinated were in that sort of July timeframe. But I think there's 2 important points to mention here. As Dr. Shepke mentioned earlier, the immunogenicity, or the amount of antibody you create, is pretty significant from these early vaccine studies. Before they do a trial like this one, they do a phase 1 trial, which is where they inject a bunch of healthy people and they just measure their antibodies over time. And so they found that not only do you get a lot, but they last a good amount of time. But another important point here, as I keep driving home, is if everyone can get vaccinated, then it's going to last a really long time, because there's not going to be any coronavirus out there. Or if it is, it's going to be insulated in small pockets, and it's going to help us. And so I think over time will tell. But the important thing is, we need it now, and we need everyone protected now, so that it can last even longer, because less people are there infected.
Yeah, I was just going to say, this is a question that everybody wants to know the answer to, but unfortunately, the only way to know is to jump in a time machine, go 5 years ahead, and measure people's blood. So we're not going to know. But that being said, we do have reason to believe that this is going to last significantly longer than influenza vaccines, because influenza which is also an RNA. Both of these are RNA viruses, but influenza mutates much, much faster than COVID. COVID is mutating. And we want to get this under control before it has the opportunity to mutate away from protection of the vaccine and monoclonal antibodies. But it's not mutating anywhere near the rate that influenza does. So I do think that we're probably going to see protection for quite some time, but there's no way to answer that scientifically yet.
And this shouldn't be a surprise to us in the public either, because we have other situations where we've had to alter schemes in the future, and we might be lucky, and this might wipe this out and we're done forever. But if you look at like diphtheria or whooping cough, people got childhood immunizations. We thought that lasted forever and you didn't need it, and then started to have little flare-ups of whooping cough, and now we're back to adding it to the tetanus vaccine on a regular basis for adults. So it's not a surprise that sometimes as we go forward, we might have to make little alterations, but that's part of the way vaccines go.
Okay.
But in an ideal world, we may not have to have the variations in the COVID vaccine that we have on an annual basis with seasonal influenza.
Okay. And then we have our last sort of pre-scripted, pre-sent in question. Should the vaccine become mandatory for EMS personnel?
I would like to think that we wouldn't, the collective we of EMS shouldn't need to make it mandatory. I think that's the reality. There are always people that aren't going to be able to get it for health reasons, but I think being in healthcare and being in EMS, I think we're all trying to put our patients first, and I think especially as the data pans out, we're going to see that this is one easy way to put your patients first. And so I would like to think that we don't need to make it mandatory, and it doesn't even need to be a question because we'll all do the right thing.
And I think we're in a good place to help with that, doing webinars like this and working with our individual EMS agencies to provide the education, and not only our EMS agencies, but our communities, to provide the education and the reassurance that, both from a safety perspective and from a disease mitigation perspective, it makes sense.
It's much better when people choose it voluntarily and are chomping at the bit to get it than when it's being forced upon someone. And it is an individual decision. But I think the most important thing is there are a couple hundred people on this webinar today, but we have many, many, many more providers out there that need this kind of information. So I would put out a plea to anybody that's on this that is a medical director, that is a system manager, operations leader, that sort of thing, that you find a way to work with your medical director and others to get the questions that people have answered so that they can make a good decision. Because for most people, when they understand the science and make these decisions, they're going to lean toward getting the vaccine or actually actively want the vaccine.
Okay, we're going to take a couple of questions that have come in either through the chat or the many, many questions that we've gotten in the QA box. So let's do a couple of quick ones here, or maybe this isn't really quick. What's the difference between the two vaccines, the Pfizer and Moderna, and what's the scoop on mixing and matching the two vaccines?
I don't mind taking that. They're very, very similar technology. They are both messenger RNAs for the spike protein. The little fat particles, the lipid nanoparticles that protect messenger RNA, the ingredients are a little different between the two of them. And in the case of the Moderna one, they may cause a little bit more inflammatory reaction than the Pfizer one. But the Moderna one's easier to deal with from an operational standpoint because you don't need to have that ultra cold freezer that you do for the Pfizer one. So the Pfizer one, you have to make really, really cold. It's not a regular freezer like you have in your kitchen, whereas the Moderna, you can put it in a regular freezer just like the one you have in your kitchen. So it's a little more stable, which is nice. But otherwise, they're very, very similar. They are both 2 shots. In Pfizer, it's day 0 and then day 21, plus or minus a few days on either side of that. And then Moderna, it's day 0 and day 28, and also a little wiggle room around that day 28 thing. They're very, very similar in terms of the efficacy. It was 94.5% for Moderna and 95% for the Pfizer. So they're really, I personally, I would take if you're interested in getting the vaccine, I would take whichever one is immediately available to you. They're so similar that I wouldn't bother making a choice between one or the other. There was a very slight increase in side effects of the vaccination type side effects in the Moderna group, but again, the vaccine side effects, you look on the CDC on pick any vaccine you want, they're all going to have the exact same stuff. The side effects are from your immune system turning on. They both do a good job of turning the immune system on. Take some Tylenol like I did when I had my vaccine, and I was just fine. So they're very, very similar, and they're both quite good.
Who wants to take the mix and match part of that question?
Yeah, go ahead, Jerry.
Well, I think the reality is, like a lot of things, it's an educated guess to do it. As Dr. Shepke mentioned, the mRNA itself is the same. It's just the lipid nanoparticles that are different. And so there's theoretical benefit, or theoretically it could work, but we have no data to support it, right? And so I think at least in Texas state, for example, what the understanding is if you're a vaccine provider and you were given 3,000 doses in week 0, you're going to get given 3,000 doses of the same one in week 3 or week 4 for Moderna. And your goal is to get the same people vaccinated. And so I know a number of countries are looking at mixing and matching, or are delaying the second doses. The recommendation has been that you can go a few days early, and if you miss your second dose, you can get it any time without having to restart the series. But I think the goal is to get it in that same 21 or 28 days as close to as possible. And I think all of the distribution plans are designed, at least so far, to get it in that same time frame. And so, I saw a comment that some agencies are deciding to delay it. I don't think that's consistent with the CDC recommendations or the distribution plan either.
I would suggest.
Go ahead, Ken.
I was just going to say, I would suggest that you stick to what's been proven. What's been proven, you take 2 shots of the same flavor. Mixing and matching, you're entering the realm of unknown. So rather than entering the realm of unknown, stick to what we know. It's 95% effective to take 2 shots of the same flavor.
How lucky are we that we could even have a conversation about mixing and matching, right? We have 2 fantastically working vaccine brands. And I, especially when it was early, I said, whichever conspiracy that you worry about, if you worry about government involvement, well, you've got Pfizer, who were private. If you worry about private sector, you've got Moderna, that was government sponsored. Whichever way, it all worked great. And they came out at basically the same time. So,
and we didn't really even mention too much about the fact that there are other ones in the pipeline. And so, there is a AstraZeneca one from Oxford that's being used in the United Kingdom. And as those other ones get enough data to be able to prove to the FDA that they are safe and effective, we will see other options also. But the key point is they all have to pass the hurdle of safety and efficacy through the FDA.
And we don't know if the nanobots in the 2 different versions or 3 different versions are going to interact with each other. So we got to be careful about that too. So, all right, another question. What about half dosing? Is there good protection? What's the efficacy of doing half dosing, like is starting to be discussed in some of the media?
That's probably Ken's same answer, and my answer when we were talking about that chart. We don't know what the response is going to be if you only take 1 or if you do a half dose. So we should stick with what the science has been tested to show us.
They do that in phase 1 trials. They try a bunch of different types of doses, and they pick the one that they found is in the sweet spot where it gives you the maximum amount of protection with the least amount of side effects. And that's why that one was chosen. So stick to what they've already done those studies to work out what the best dose is. So I would stick to that.
Okay. Another question, what types of treatments are showing effectiveness in the adolescents with MIS-C?
Yeah, I think you've got your answer there. We're not sure. They're from some of the information that I've heard, they're using monoclonal antibody infusions and convalescent plasma. I've not seen a lot reported on that yet.
And this is really being studied at this point, and it's not even. People are thinking of it as infants. People have been thinking of it as sort of like Kawasaki's. The more we're seeing and the more the definition is changing, it's not really looking exactly like Kawasaki's. And I worked a shift in the emergency department over the weekend when there was a 19 or 20-year-old that met the criteria for this. So, people are starting to make this diagnosis in adolescence and beyond. And I think we don't know a whole lot, but we're actively looking at all of this.
Okay, excellent. And we're going to ask one question, and you hopefully it's not going to put anybody in an uncomfortable spot, but show of hands from the panelists, how many of you have been vaccinated already or are planning on being vaccinated?
I'm getting my second dose of Pfizer tomorrow.
For those of you who haven't seen it, these gentlemen who arguably are the most knowledgeable physicians in the EMS community related to this topic have all been vaccinated or getting vaccinated. So that probably will tell you something. Well, we certainly want to thank each of these panelists for sharing their exceptional insight, but we also want to give special thanks to Dr. Rona Miller from UT Southwestern for providing all of the links and additional information that we've been sharing in the chat window. Dr. Miller has been an incredible resource throughout this webinar, and I want to thank them very, very much for doing this. These panelists also took a lot of time out of their incredibly busy schedule to be with us today. In fact, Dr. Shepke joined us while he is, quote, off duty, unquote, enjoying a much needed vacation. Watch for the links for the recording of the webinar in the next few days. You'll be seeing those coming to you from the various associations that you may be part of and in the general public domain. So thank you again for joining us. Have a blessed rest of your day, and please stay safe.